Good afternoon. This is episode 8 of Coffee with Colette, and I'm here with Qasim Butt in San Antonio. Welcome.
Hello, how y'all doing?
I've been really looking forward to this episode for quite some time to talk about COVID-19 and hopefully get to dispel some common misperceptions or myths out there and hear from you and what's going on in San Antonio and Central Texas, Central South Texas from a physician and an insider's perspective. So welcome.
Well,
And
thank you for having
so
me.
glad to have you here.
Yeah.
So give a little introduction. May I just call you Qasim?
Qasim, actually, but yes, you can call me Qasim. You messed it up
Just
twice in a row, so
corrected
it's
me.
totally cool. So, remember, the Q is a K. So
The Q
yeah,
is a K.
yeah.
Qasim. Okay.
Qasim, yeah.
I've written it down twice, and for some reason,
Don't worry
it's
about
just
it. Don't worry about
okay. It's like people calling me Colette or Colette. They do it all the time.
it. Yeah.
So I'm gonna be paranoid about it.
Don't worry
Qasim.
about it. Don't
He's
worry
the
about it.
current he's the current chief of medicine at the Metropolitan Methodist Hospital and treasurer of board at the Texas Kidney Foundation. He practiced clinical nephrology and is a certified interventional nephrologist and is able to handle pretty much all issues related to dialysis access. And in 2019 was nominated for the Grand Ace Durr Award by the Methodist Healthcare System. He's board certified by the ABIM in both internal medicine and nephrology, and is a skilled interventional nephrologist and is certified by the American Society of Diagnostic and Interventional Nephrology. That's a mouthful. Yeah, he received his training at LSU Health Science Center and completed a residency in internal medicine and a fellowship in nephrology. He enjoys mentoring young aspiring physicians, allowing them to shadow him, giving real life practical advice will help them on their journey to a career in medicine, which is so needed. He's also a mentor for several years with Big Brothers Big Sisters, trying to improve the life of adolescents from an underprivileged background. And Dr. Butt is also very passionate about not only raising awareness of kidney disease, but also the epidemic of poor health in our nation, which is widespread. He's worked with the Kidney Foundation, Texas Kidney Foundation, for many years, and he volunteers for health screenings, fundraising walks, engages in public speaking events, and the general public about kidney disease. He has a professional Facebook and YouTube channel called Your Kidneys, Your Health, and the Facebook link and the YouTube channel we'll put down in the links below for the audience. And he does entertaining videos that break down health-related topics in a really entertaining way. And he has a myriad of awards and leadership roles in the area that we don't have time for today. But I want to thank you for being here and appreciate you taking time out of your busy schedule to be here with us.
I appreciate that, Colette. I'm really excited to do this. I'm always about getting out education, especially about, well, health in general, kidney disease, but also right now with the pandemic of COVID-19, I feel like we have to clarify so many misunderstandings out there, and so that people understand and how we can better cope with what's going on out there. So,
Right.
yeah.
So is there anything in my introduction that I missed or got wrong or you wanted to correct?
No, pretty much. So what you guys need to know is this: I'm a kidney doctor. I'm a nephrologist. So I handle people with kidney disease, people on dialysis, those kind of things. I'm not an infectious disease specialist or an epidemiologist, but I have had experience with COVID-19, and I read extensively on it as well too. So I like to give you guys information about it, and dispel myths, but also see where we're going. I mean, I'm curious as to I feel like it's changed in the last 2-3 months, and the protocols, the understanding, the scientific understanding, the medical understanding, the effects on society, all that kind of stuff. So this is ever evolving, right? So it's constantly changing.
And it seems that that's kind of been part of the confusion that happens is because of that kind of fluidity that
Yeah.
still learning from
And
everything.
I think that's it. Like, when this first started, I actually did a video called COVID-19 in 5 minutes. Just kind of broke down COVID-19. And in that video, I'm literally telling people don't wear masks. And that was the CDC, guidelines and the WHO. I'm not going to make up my own guidelines because I'm not qualified to do that.
Mhm.
So, and I wonder, looking back, were they doing that just to protect masks for the healthcare workers at that time?
Mhm.
Because if 6 billion people or 300 million Americans run out to get surgical masks, that could, you use up all the masks that would be otherwise used by healthcare workers. But then we tell everyone, no, wear a mask. And so I can see the confusion there, and then so I think like it goes back and forth, but also like we have no trust in our media, we have no trust in social media, we have our own implicit biases that a lot of like social media does to us, and so we there's so many myths and so many misunderstandings that really need clarification for the sake of all our health. So
Mhm. So I'm gonna ask a little bit about you because I want to get to know you as well.
yeah.
So where I usually ask this in all my interviews. So where do you hail from? As in the
Mhm.
Texas say, where do you hail from? How'd you end up in San Antonio if you're not originally from there? And what pronouns do you prefer to use?
Pronouns? Dude, I'm a dude, so
Okay.
he is fine.
Uh-huh.
So as far as where I'm from, I grew up in New York City actually.
Okay.
And so we grew up there. When I was 16, we actually moved to Midland, Texas, which is crazy, but we actually moved to Midland, Texas. I eventually went to left Midland. I was there for like 2 years in high school, and then went to Baylor undergraduate, and then was there for a while. And then in 2000, I went to med school at St. George's University, which is in Grenada. So I was there for 4 years. After which I did my residency and fellowship in LSU, Shreveport, Louisiana. So I did residency in internal medicine. And then in the 2000s, a lot of people were specializing at that point. And
Mm-hmm.
so especially I chose was nephrology. Now it's funny because you actually go to med schools and you go to like residency programs and not specializing as much, but back in the 2000s you did. And so I chose nephrology because it's kind of an all-encompassing field. Believe it or not, the kidney organ is one that's involved the kidney organ, but what it does is so complex it involves the whole body. So it's not like it's just one organ, one system I can just check out. I have to kind of know the complete person to understand what's going on with their kidneys, but their overall health in order to better their kidney function. I did my training there, and then I wanted to come back to Texas because my parents were in Texas, but my wife is from Texas too. And even practicing wise, Texas is a great state to practice in, and as far as income, but also just quality of living. Also, we just love Texas. Like it's just a nice state to live in. People here are nice. So we eventually moved. We found a job here in San Antonio, and I moved here in 2010. So I've been here almost 10 years, and it's crazy, but I've been in one place for 10 years, which is like, oh my God, I can't believe it. But yeah, but we're happy here in San Antonio and we enjoy it. So yeah.
So how did you, and before we get moving on into COVID, a last little question about yourself. So how did you get interested in medicine and becoming a physician?
That's an interesting question. So you want the real story, or you want the bio?
The real story.
The real story. So
Mhm.
and this is something most people will not tell you, okay? But I am the oldest male in an Asian family. And
Mhm.
so if you grow up in an Asian family as the oldest male, or even this ever, you are pushed to do medicine. And so it's just a respected field in our communities, right? And so if you notice our doctors wise, like so many of our doctors are either Indian, Pakistani, South Asian. And it's because of that. So it's not like I was forced to do it, but that was my inclination to do it at that point. I do love it. I do enjoy it, and so that came along with it. But that was probably the main thing that kind of pushed me along in my career towards that way.
So I imagine San Antonio has an extremely um, so when I'm also a chaplain, and so I did my part of my postgraduate clinical hours in San Antonio at Children's Hospital, but also at University Health.
Mm-hmm.
And the kidney disease is, it's a whole nother, it's totally, I mean, just San Antonio seems like a mecca of what's
Oh, it's horrible. Um, it's pretty, it takes you back. It takes you back when you first get here and you see it. The main thing is what's rampant here is diabetes. So diabetes is so utterly rampant here, especially in the Hispanic community. It is just utterly rampant, and that just they just have that in turn has effects on all their organ systems, right? Like people think they get diabetes and that's it. Oh, my sugars are high, but no, that when you have that high sugar for a long period of time, it has end organ damage, right? So it'll affect your eyes, it'll affect your brain, causing a stroke, it cause a heart attack, and of course it can also affect your kidneys. Now people don't understand that because the kidneys are such a complex organ, and I made this video called "Kidney Disease is Sexy," but it's not. Like it's just not sexy. People don't care about their kidneys because they don't understand it. They just think it's about making urine and that's it. But when you have this rampant diabetes that goes around here with the obesity, let's just be honest, the problem is the obesity, right? That leads to everything else. So once you have that rampant diabetes, rampant obesity that leads to diabetes, then it leads to kidney disease. And it's pretty shocking because a lot of times you get here and you're like, oh my God, there's so many 30, 40-year-olds with kidney disease, and they ordinarily shouldn't, but here in San Antonio, it's so prevalent.
So I'm going to move into some numbers in which it was interesting because you can't, I was looking on the Bexar County website as opposed to Comal County website, and they're set up a little different with cases, which is, apparent, county to county difference. But I noticed that in Bexar County, they said 74% of cases are Latinx or Hispanic, and the majority are from 18 to 40 years old. Which I was really,
I'm sorry, this is in Bexar County?
Have that, yeah.
Okay, yeah.
And we don't have that data in Comal. Like because so many people identify, they only have it as white. In a lot of people that are Latinx identify as white. So there's no
delineation or whatever. Yeah.
So I'll give a few numbers here, and then we can kind of move in. As of today in Comal County, there were 1,667 reported cases, 1,300 confirmed, 37 deaths. In Bexar County today, there were 28,633 cases with 251 deaths. The difference is in Comal County, there's 156,000 people in the whole county. And in Bexar, it's a little over 2 million. And in Bexar, 74% of the cases were Latinx or Hispanic, majority being 18 to 40 years old. Source of exposure is about 57% from close contact, 37% by community transmission, and 6% travel, which I didn't find that on the Comal website. So it was good to see. The more information you have, the more data you have. So what has been your experience with people that have kidney disease and then COVID?
Well, so what you have to understand about COVID, COVID is a respiratory illness, but also has other effects as well too. But people that have other diseases are more predisposed to getting it and more predisposed to having worse outcomes, right? So myself and yourself, I don't know your health, but let's just, for the sake of argument, we're both healthy people, and we're observing social distancing and all this kind of stuff. We're less likely to get it. And if we did get it, we probably have a better outcome. Unfortunately, people with kidney disease have almost like an inflammatory process going on in their body because their bodies aren't being cleaned properly and all this stuff. So they're predisposed to getting it, but also having a worse outcome. So what I've seen is, people that get it it depends on the severity of their kidney disease, but the people that can get it can get really sick and wind up in the ICU. So we have had several patients that have gotten it, and we had several patients that are dialysis patients that have passed because of having COVID-19. And perhaps if they didn't have kidney disease or were better shape, they probably wouldn't have had that outcome. You see what I'm saying? So
are there other than kidney disease, are there other pre-existing conditions that are more prone to complications to COVID? I imagine.
Yeah,
Any kind
I
of
would say any illness, any illness in particular. Like, I mean, any diabetes, high blood pressure, a heart disease, liver disease. If you have an autoimmune disease, especially, I would be very concerned if you have an autoimmune disease, because you're oftentimes, like, say if you have a lupus, or say if you have a kidney transplant or something like that. If you have an autoimmune disease or have a transplanted organ, you're on what we call immunosuppressive medications, which actually suppress your immune system and decrease your ability to fight. So you are definitely more predisposed to it. And the other thing is, if you're a smoker, predisposed to worse outcomes. And of course, the big one here, no pun intended, is obesity as well too. Obesity itself is a bad state to be in. So and in Texas, we see it everywhere. So that can definitely lead to poorer outcomes as far as COVID-19. So.
Okay. So I'm going to move into some questions about testing, because seems to just be a lot of, there isn't a national consensus. Let's just put it that way, much less from county to county or state to state.
Yeah. And I think it has to do with the availability of the testing in the region you're in too. But yeah, go ahead. Yeah.
So for the public, I'm going to give, or for the audience. So COVID-19 is seen, that the white ball with the red spikes. And so the PCR test looks for genetic material in the white ball, while the antigen test looks for proteins on the red spikes. Is that correct?
Yeah. So you could break it off. Let's just say two categories, right? You can say there's diagnostic tests and there's serological tests, right? The diagnosis test is looking for essentially looking for particles of the virus. And what you're talking about, the molecular test, that's looking for pieces of RNA, DNA that match it. Though that is probably the most accurate test. So it's the molecular test, which is the PCR, if you will, the PCR test. That is the most accurate test. The other test, and that's the more rapid test, is the antigen test. That's actually looking for proteins off that virus. So it's not looking for the DNA or RNA, it's looking for the proteins off of it. I've heard that those can be pretty accurate, but the negatives are sometimes wrong. And so if you have symptoms, you may need to get retested. So those are two things you want to look out for. The other and last test is a serological test. Now, the serological test is not actually looking for virus particles. It's actually looking for your response to a possible infection with COVID, right? So it's essentially looking for your body's response to it. So when you get infected with a virus, your body makes what we call antibody to that virus. And those are kind of floating around your system. So in those serological tests, they're looking to see if those particles are there. Now that cannot be that test in itself, the serological test, cannot be used as a test to test if you have the virus. It's testing to see if you've had the virus. Do you see what I'm saying?
Okay.
So the serological test is saying, hey, you have had the virus at some point, and that your body has had a response to it. So those tests are not as reliable or not as useful. Do you see what I'm saying? Because if I'm sick right now, I got a fever, chills, and I'm debating whether to go to work or distance myself from my kids, I want to know if I have it. So the best type of test is to get the diagnostic test, which are either the molecular test, which is the PCR, or the antigen test, one of those two. So
the PCR is the swab test, correct?
From what I understand, both the antigen and the PCR are both the nasal swab test back there. I've heard now that they're actually experimenting with just sputum tests as well too. But yeah, they're both done like that. It's just, I think the antigen test is just they've had the rapid test, which come back in like 10 or 15 minutes. Those are the antigen tests. Although now the other tests, the PCR tests, are coming back quicker and quicker. So, but it depends on what I've realized is it depends on the facility you're going to. And I'm not gonna name names of facilities, right? I'm not gonna do that. But there's one primary care facility here in San Antonio that offers rapid tests. You find out in 10, 15 minutes. Lines are out the door if you ever go on their their waiting list thing. But other hospital systems that offer it takes a day. So, and some take a few hours. So if you want to make sure you've got it or not, I would say go with the PCR, the molecular test, and for sure to make sure. But
okay, because I've heard like people getting like the quick testing and then they go about their day.
Yeah.
They actually get sick and they're like, oh well, whether it was a false negative or they just took the test too early.
Yeah,
Maybe they were
that's the
exposed and
yeah,
that's
and this goes back to our previous point. Like, we are in the game. Like, we can't have people Monday morning quarterbacking when we're in the game, right? It's too difficult. Like, we're learning as we go here. So yeah, it could be a false negative. It could be a false negative. You may not have enough virus built up in the back of your nasopharyngeal area yet to pick it up, or it just could be a false negative. So you may have to get retested again. So I would say if you have persistent symptoms, you may want to go back and it's not getting any better. Maybe you want to go back, and you're someone that's had exposure, right? Like your sister had it, or you were at work, your healthcare employee, a healthcare worker. Definitely, you would do that. So I would say possibly get retested. I would say the serological. I actually had the serological test done, by the way, the one that checks for the antibodies. I don't see the point of it as of right now. So I would stay away from the serology test. I just don't see what that's going to do for you. It tells you that you may have had it, but then you have to remember coronavirus is a virus, and the term coronavirus is a virus applied to many viruses, right? So there's apparently cross reactivity to other coronaviruses that you may have had in the past too. So I don't know what the utility of is, and I hate to do tests that don't necessarily change the course of what you're doing. You see what I'm saying? Mm-hmm. So I would definitely try the PCR. If the antigen is available, do the antigen. But from what I understand, the best one is the PCR. So.
Okay. So I know that just this last weekend that they removed about 4,000 cases from Texas, San Antonio, Houston, and Dallas because of the probable. They changed the definition of the probable to be included in the state cases. So what I guess.
So you mean the PUIs, the people that we call PUIs, person under investigation?
Like they had a positive antibody test or also symptoms. There's those three things. It's like that were on the CDC website, but then the CDC changed it, and so that. And I don't know if they're just trying to get a same thing across the board for everybody or.
Also, you're saying they added people to the list of deaths or list of people diagnosed that died essentially because they.
They took them off because the positive were through the antibody test. Like it was like the epidemiologist said, yes, you were positive for the antigen test, and you had symptoms. So. But you're still under the probable for some reason, and it had the three reasons why. But they kind of so that all these nuances that are kind of evolving, unfortunately, are kind of playing into unfortunately like that people have a distrust now for what fluidity and the kind of evolving nature of it all, and it's unfortunate.
Yeah, like that's an problem. And quite honestly, I haven't heard of that before. That the adding of the cases. I'm sure there's going to be backpedaling.
Well, they took them off.
Yeah, they took them off. Yeah. So I don't know, how that is, but yeah, I talked to an infectious disease specialist like a few weeks ago, and he says this is the first time, and he's an older guy in his 70s, and he's saying we're watching a disease evolve in front of us. Right. Mm-hmm. This is the first time in his career he's ever seen that. And he lived through HIV when HIV came out through the 80s. And even then it didn't evolve like that. Right. It was in a certain population. There were certain behaviors or certain things you did that possibly made you predisposed to it. But this could be anybody. Right. So we're watching this evolve. And so as we're watching our evolve, our observations will change and how we approach it will change. And so so it's not like, again, it's not like a conspiracy theory or like we're trying to mess with you or we're trying to fudge the numbers. It's just literally we're going day by day, just like you're going day by day.
Right.
So if you can give us that understanding and bear with us during this, it'll make the whole thing a lot easier. And so I'm guilty of it too. Like 2 months ago, literally 2 months ago, was it 2 months ago? 3 months ago, I was telling people do not wear masks. And I'm telling everybody to do it. Okay. So I'm just as hypocritical in this scenario, but again, it's evolving. So, we're going to have to, we can Monday morning quarterback in 2021 or 2022, right? It's kind of hard to do it. So, but yeah.
So what's it like in like in San Antonio and kind of your experience been like with COVID-19 and like the hospital setting as well?
So the hospital setting was interesting. So the way I describe it is I think it's overwhelming, but not over capacity. Do you see what I'm saying?
Mm-hmm.
So it's if you look at the numbers, we're not at 100% or 102% capacity or anything like that. Now I work primarily with the Methodist system. I can't speak to them, speak for them, but the numbers I've seen, it's not like we're over 100% capacity. We're at 97, 93, 90, 98, that kind of thing capacity. But the reason why it's so overwhelming is, I've never been to a hospital where whole floors are dedicated to one disease process, right? Whole floors, not just one floor, what I mean, like, I've never been somewhere where the flu is taking over 3 floors of the hospital, So COVID is pretty scary because they literally are locking down rooms, locking down, rooms, whole floors. So some of them are making makeshift walls. Some of them are putting tarps up, depending on the hospital system you're going to kind of lock it in. And it's pretty scary actually to walk in there. Now, again, it's not, I'm not scared about getting it, but again, the danger is if I get it, I could pass it to other patients that can get sick too. So it's pretty intimidating environment. And I remember going and I made a video about this too. It's called Scary. San Antonio, this is scary. But when I walked in, I hadn't been to the hospital. The video I made was like 3 weeks ago. But when I had walked into the hospital, I had been out of the hospital for about a week and a half. And then when I get there, this is when it just had hit. And I had heard from my partners that it was bad, but I had no idea when I got there. I'm like, oh my God, this is pretty scary. Like you walking in, and just so you guys have an understanding, when we walk into hospitals, the hospitals are pretty much locked down at this point. You have certain points of entry. Not everyone can get in. Family members are literally not allowed to come in sometimes. And so some people are dying without family members there, which is scary. But you walk in, they take your temperature, make sure you have a mask, all this stuff. But this time when I went in, I had a face shield, I had an N95 mask, I had a gown over myself. And even what's funny is after that weekend on call, I actually got one of those respirators, those little,
Oh yeah.
yeah. So I actually got one of those just for the comfort and the proper seal it has over your mouth. Do you see what I'm saying? Yeah. So I got that because some nurses had recommended it. When you see them, like some of the ICUs are just full of COVID patients. Like, they'll have a dedicated ICU, but then there's overflow from more COVID patients into the other ICU. So they'll have like 2 ICUs in those hospitals and it'll be overflow there. So I've never seen a disease do that. Do you see what I'm saying? Or like, I've never seen that before. And again, like, the death rates are not that high. If you look at the death rates, right, I think even Bexar County, we had 251 die and we had 28,000 affected. I did the calculation. It's less than 1% mortality by those numbers. But what's scary is the sheer contagiousness of it, right? It's not just about, the death rate. It's about how many people it can infect, right? So if the flu infects, 10,000 people and has, say 100 people and has the mortality of 2%, it kills 2 people. But if COVID-19 is far more contagious and affects 10,000 people as opposed to 100 people, if that same 1 or 2% is a lot bigger of death rate. Do you see what I'm saying? The actual number. So that's what you got to be afraid of. Also, just putting you out of commission. Getting it. It's not just about getting it. Like it puts you out of commission for at least 2 weeks. At least 2 weeks. You can't go to work for 2 weeks. You have to watch yourself around other people because you don't want to spread it. Like I am not as scared for myself or maybe with my wife or kids, but I'm scared of it for my parents. Like I haven't seen my parents in months because I will be the vector that brings it home. So those are kind of scary things. And what's really scary, I think, was when this really first started, I was actually genuinely scared. Like I was washing my hands every second. I was like, I took my shoes off. I was taking showers every day when I got home. The whole 9. And I still do that when I feel like I've got a lot of exposure to COVID patients. But right now I'm doing a lot of telehealth, so I don't see that as much. So I'm not as neurotic about it. But it's changed our lives. So I've never seen this. And again, like what my ID doctor I talked to said, we're watching a disease process or a virus like evolve in front of our eyes. Like we're watching it, and it's pretty scary. So.
Well, so I'm glad that you mentioned the flu because that's one of the reasons why I wanted to talk to you because there's a lot of these sayings that people have or you hear on social media or Well, you shouldn't really, it's not really that big a deal because the flu kills more people every year. That's a pretty common one that kind of goes around on social media and with
Yeah.
people. And I'm like,
But it doesn't kill them within 2-3 months like that,
right.
right? Like it doesn't do that. Like I've never seen an ICU full of flu people. You see what I'm
Hmm.
saying? I've never seen people gowned up and scared, all because of the flu. And so it's just not as contagious. So like it's hard to explain. You're completely right. We can go into that whole argument that drunk drivers kill more people than COVID or whatever, different things
Right.
kill more people than COVID. We can, but it's just the impact it has and how quick it moves. And so, we don't want it to contaminate so many people. Again, the vast majority of us will be fine. We will be
Hmm.
okay. We'll have some symptoms. But it will, if it gets to 200, 300 million people, it's going to kill 2 to 3% of those. And so
Hmm.
that's the number we're scared about. Right. And so that's what I think is, what people have to kind of take into account. The flu won't do this. The flu hasn't done this. Like it doesn't
Right.
move this fast. So
Right. So I have a question and about, so could you talk about herd immunity?
okay, so the herd immunity thing. So we're still wondering if there is going to be herd immunity from this and how fast that will come. So
And does that come through? Doesn't herd immunity usually come after a vaccination? Like,
yeah, well, that's the whole point. Well, it can't come from your own autoimmune response, your own
right.
immune response, right? So again, like I get it, you get it. We built an immunity, we built an immune system immunity to it, or we get it via a vaccine that passes us the immunity as well too. So we get that, we get exposed to the virus, our bodies make an antigen antibody to it, and that's how you get it. So it's a little bit of both, and I agree. Like maybe when more people are God forbid infected or whatever, and you have more of herd immunity. I think you need a herd immunity about 40 to 60% for it to slow down the
That, I
transmission.
mean, doesn't it take several years, if not
Yeah,
longer?
it may take some time. The other thing is what's interesting is like we don't know again the disease is evolving, right?
Right.
So we don't know when we develop those antibodies how long those antibodies will last us, right? Like will it will stay in our system, those antibodies stay in our systems for a few months, a few weeks, a year? Are we going to have seasonal COVID vaccinations? Yeah, every year, how we have a flu vaccine every year because the disease evolves. Are we going to have that? Even the new vaccines, some of them are tested. What I understand is they have to give you initial one and then they give you another one a few weeks later. So, to boost your immune response to it. So again, I'm hoping at some point we do get that herd immunity either from certain amount of people getting it, but also from a possible vaccine. So we'll have to see how that comes about.
So I'll admit, like, I've never had the flu in my life.
Oh, I haven't either. So
I've
I
never,
don't want it.
also never had a flu shot.
Oh, you never
But
had a flu shot?
even when I worked in hospitals, I got a religious exemption.
Are
Not
you
that I
serious?
don't, but I'm like, if I've never had it, I'm not going to start now. And
Yeah, yeah.
but I also am a kind of a bit of a health freak too. So I literally spend a lot of time and money and energy around keeping myself healthy
Yeah,
in a lot of ways. But
yeah.
yeah, I've never had one, and so I guess there is maybe a little bit of, well, if you, so why would you, this, I don't need to like deter into a different conversation, but if you
Yeah.
say, if you have a natural immunity to something, um, specifically with COVID, like say you have a natural immunity, why would you get a vaccine if you have a natural immunity? Like,
Yeah, well,
right?
so this goes into argument. Like we can go into this too, because I actually do believe the reason why we're probably more worried about this disease than others because Americans are not in shape and not healthy. So
Right.
that's so if we were in health, like again, like as I speak to not being that worried about COVID for myself, I'm more worried about other people. That's where you have to really start thinking about it. It's not about just you;
Right.
it's about other people. So, but when I'm talking about for myself, like I'm a relatively healthy 40-year-old male. I work out in the mornings. I relatively eat right. So I'm a normal body mass, body habitus. So if I get and I have no comorbidities, likelihood is I won't have a bad outcome. But unfortunately, especially in San Antonio, most people aren't in that camp. You see what I'm saying? So
Yeah.
I worry for them. Just to give you an example, there was a 47-year-old guy I saw in the ICU at a hospital I went to, and he came in with COVID. And 47, he's not that much older than me, right? And guess what? He had underlying diabetes and high blood pressure. Never saw doctors for whatever reasons. So he had all these underlying conditions that predisposed him to him. And unfortunately, I think a lot of people don't go to the doctor or don't take their health seriously. And this is a side conversation, by the way. This is total. I can go on this tangent forever. So because they don't take their seriously, they only find out about disease process when they say, "Hey, I gotta go because of a job." They check up, or oh, my wife is making me go at 50, or like I'm going, whatever. So then they find out about these things later. So I think again, that's where I'm kind of worried about a lot of people in San Antonio, because they could have adverse outcomes, and especially because of obesity. So,
and there's, I mean, there's several instances of friends that I know that have gotten it that are really healthy.
Yeah.
It's just,
no, it can. And how was their experience, by the way? Just curious. I'm just curious.
Well, a friend of mine in Austin, she said it felt like she had rocks in her lungs.
Yeah.
It was just this, I mean, this weight and then I have another friend who his best friend that was in Corpus.
Yeah.
His best friend and his best friend's fiance just passed away, and within a few days of each other, and were seemingly healthy and in their late 20s, and it just
in the late 20s. Oh my God. Yeah. But you realize this is where people have to take the contagiousness of the disease more seriously. Because again, like there's 20-year-olds killed by the flu every year, but because the flu doesn't get everywhere, it's not a big deal. But because COVID gets everywhere, some of those healthy 20, 30-year-olds that otherwise would be fine can die, So again, the mortality is small, but it's that's where I think people don't take the contagiousness part seriously. But that's what I wonder. Like I talked to one of my medical assistants. She had gotten COVID. Her experience was more like more like a flu. I've heard people having lingering effects afterwards, like pretty significant fatigue, things like that afterwards, and it lingers for a while. So it's not like it's easy, or it's just like a quick cold. It's probably going to be like a Mack truck flu kind of feeling, if you get it. So
and I've heard that. I mean, this will, I guess, time will tell as y'all physicians continue to look at the data and see patients, that the long-term effects we don't really know yet, especially with people with those, that are immunocompromised or have underlying conditions, and how their lives are going to be completely changed.
Again,
something that may happen.
Who knows? They could be like a post-COVID problem. Who knows? Like,
And can we get it again, or can people get it again? I mean, I
have no idea. Like I've heard that I heard that it's possible to get it again. I've heard these rumors that you can again. This goes to the immune response and how long those antibodies linger. And who knows, this COVID evolve or
does it
mutate?
Does it evolve? Right.
Yeah, mutate and change like influenza. It's so contagious. So
I've heard a little bit about, or I've read an article or two. Now whether how, not sure about the truth of it. I didn't really look into the data, but that some people are saying that like the strain in California and the strain in New York and say the strain in Florida are slightly different.
Oh, really? Yeah.
So that's interesting to see.
Yeah, no, it could be. I don't know if they've actually, and that goes to what they're doing with vaccines too. So what are they coming up with? And to the point of vaccines, like I think there's like 13 companies in the world right now working on vaccines. And so, and I think, was it the Moderna? Moderna is the company that came up with it. They're recently going to push their drug to phase 3 now, and they're going to incorporate 30,000 people. So they had like test runs of 3,000. So the trials of medications or vaccines go through 4 phases of trials. Right. And typically this is done over years, by the way. So they're doing this over months now, which is crazy, right? This is how fast things are moving. And again, this is where you have to kind of, see where we are in this. But they're going to start doing phase 3 trials.
Aren't they testing? I read something where they were testing 30,000 people in Africa, and I was like, aren't we ever gonna, I mean, is there gonna be a point where we start like not testing on people that have been historically oppressed and tested on?
Well,
I mean,
I
that's a
don't
whole
know.
nother ballgame of
I
something.
thought it
But
was Americans, by the way. I thought they were going to do the phase 3 here, the
well,
30,000 in America.
there was 30,000 Africans that were being tested on, but this is like a month and a half ago. So I haven't heard about what resulted from that, but it
What
was
resulted
just
from
like,
that? Yeah, I mean, I
what?
think, well, yeah, I guess you have to test it in different populations too, because you just don't want to test it in Americans or Europeans or whatever. So you may
Right.
want to test it in other people's too, just to see if you get an
Hmm.
appropriate response to whatever mix they have in that immune mix they have in there. So
Hmm.
that's the interesting thing. So I think over the next few months, I think Dr. Fauci, he said like probably he expects one in 2021. I saw some optimistic people saying or fall this year, like you're
Hmm.
gonna have some vaccines. So it's
That's so
up.
fast.
That is crazy fast. That is crazy fast. And again, like I can't point to the development of it. I'm not. That's not my specialty, but that is extremely fast. These trials take typically very long time to get the approval and everything. So
Wow.
yeah.
Okay, so let's move into um, mask wearing. In the all
Oh,
in Texas, there seems to be this kind of, there's just this freedom of my, you're taking away my freedom. Which, I mean, Texans have a very independent spirit.
yeah.
However, let's let's get into the nitty gritty of mask wearing. And I really appreciate the aspect that you were honest and said, hey, at the beginning of this, I said not to, because it seems accountability is, I think, is huge, not
Yeah.
only in life, but specifically when you're dealing with a global pandemic, to say, hey,
Yeah,
look.
yeah. There's a lot of like, assumptions that I had during this that were wrong.
Mhm.
Like like when I heard about it was in China in January. In January, I was like, okay, what's the big deal? So I never thought of it. So I think just moving on and saying, okay, my bad. Like I did make wrong. But as far as the mask wearing, I mean, I think at this point it's kind of crucial that we do this. Now, yeah, what I've realized is, culturally, we're a very independent society, right? America is individualistic.
Mhm.
That has extreme benefits to our society. We get to be free thinkers and have free mobility and do different things. Whereas but in places that like or in Asia, particularly Japan, Taiwan, those places, they have more paternalistic societies. So where you tell them they obey authority better. So you tell them wear masks, they wear masks. And also, let's be honest, they've had experience with this SARS and other things in the past as well too. So they're ready. They got those masks in the pocket and it's like, ready to go. And they're like, yes, sir. And actually there's like in those cultures, what's interesting, there's a shame, right? So if you were to go out without a mask there, they would all look at you and like point fingers and,
Mhm.
oh, Colette, what are you doing? Where's your mask? So it's a different society. But at this point, I think we have to just encourage people to wear masks. Now, the CDC, I went on the CDC website, they still recommend pretty much cloth masks for everybody. But if you are someone that has like disease processes, other disease processes that you're predisposed to getting worse outcomes, perhaps you should get a more medical mask and wear those. But cloth masks are sufficient, I think, at this point. And as long as you're within social distancing, right? You're doing the observing social distancing, staying within 60 feet, not 60 feet. Sorry, that
That's
would be
really
really
far
far.
away.
That's really far. 6 feet away from people, you're cool. So just so people understand, the main mechanism of transmission of the disease is respiratory droplets, right? Like when you cough,
Mhm.
sneeze, whatever, it gets out there or gets on surfaces or whatever. But there is evidence to say it can be aerosolized within a certain range. So with everyone 6 feet, it's possible that it can stay in the air for a little while. So it's kind of crucial that you do, that you stay away from people. But also when you wear that mask, guess what, dude? You're blocking anything that's coming out of you, right? And so that's actually very helpful. Especially again, it's not for yourself; it's for other people, right? Again, you may be a 20-year-old dude going to Padre Island having fun, but your grandma at home when you get back is not going to
Right.
take well to that. So the mask thing, is kind of crucial at this point. It's almost like the basic thing you can do at this point to help with the disease process and help stop spreading the transmission of it, or at least slowing it down. Excuse me. The whole goal here is not to, you can't stop the disease, right? But you can slow it down and flatten the curve, kind of thing, right? So that's what they're trying to do. And the flattening the curve is until they come out with a drug or come out with a vaccine that can help fight the disease, right? So.
Right. And at the beginning, they were like, you know, it seems that people were like, well, when it gets warmer, it'll naturally go down. And we're seeing.
I was wrong about that too, dude. I was
true.
totally wrong about that. I really thought that would be the case. I was like, dude, summer, Texas, nothing can survive that thing. My plants, my lawn doesn't survive. How does COVID-19 going to survive that, right? So I was completely wrong about that. I really thought, hey, we're opening up in the summer, maybe a good thing. You know, maybe it won't spread disease, but you know, that goes against the logic of how it spreads rapidly in India, Pakistan, all these other places too. Those are hot places too, and it spreads really rapidly. Again, you have population density issues there too. They're kind of close together.
And like here, I mean, we're a major tourist area. So New Braunfels is, I mean,
New Braunfels is so nice. Yeah, absolutely. Yeah.
You know, people, and that's why we have such a spike between 20 and 29-year-olds, because that's the majority of the people that are spreading now. Is because, or getting positive now, because those are the people that are like, I'm going to the river.
Yeah.
Hang out with people from Houston and Dallas and all these other places that come in.
Yeah. And I'm not gonna hate. I'm not trying to make an excuse, but I remember myself in my 20s, and I was kind of I was kind of a moron too. So like I would probably hell with this, I'm going, you know. But at this point, like I didn't grow up in a pandemic. Right. So it's a different scenario. So you know, we have to kind of push that on people so they understand it. I'm glad Governor Abbott made it lawful, you know, a law that we have to observe it. I'm glad that you know, certain businesses that open say you have to wear it in our facilities. That's very important as well too. I think that's how we get people to wear it. You know, and then we'll have to go from there.
So I have a question. Feel free. You don't have to answer it if you don't want to. But so like I have friends in Germany, and they're, you know, they've pretty much, they haven't, I mean, they're not completely COVID free, but they lock down. You know, Germans do everything very rigid.
Yeah. Again, they're like, culturally, yeah.
I mean, they shut it down. I mean, everybody, it wasn't just distancing. They didn't leave their house. I mean, it was locked down for a good solid month. If not a little bit more than that, and then they knocked it out. So I guess what I wonder is if we would, and mind you, the United States is a lot bigger. We have a whole different, there's a different culture, a lot of different cultures that live together. So what would it have been like if we would have had that same response that some countries did, that just, you know,
locked it
down from the very beginning? You know, would we have, instead it seems like we had 50 states that did everything completely different. There was no unified front at all.
Yeah.
And so I guess my question is as a physician, and you end up not saying you're epidemiologist because you're not, but what is your prediction on how this is going to go when schools open?
Well, that's a really interesting one, because me and my wife had that debate too. So, you know, it's so difficult because, you know, me and my wife were talking about it. You know, obviously I'm a physician, I make good money, and so we can afford to have our kids stay home. You see what I'm saying? And so there's a lot of people that really can't afford to stay home. They just simply can't. Like, and the thing is, like, so I'm gonna not focusing on the other side, but so as people in the general public or in the business community, they are very like scientifically illiterate, right? So, you know, they don't understand science, they don't understand the basics of it, they don't understand how it works, the methods, the phase of the trials, all this other stuff. But, you know, many people in the medical community are, you know, financially illiterate. Like, they don't understand the economy and everything else as well too. So you have this kind of balancing act that we have to play. So, you know, and it's so difficult to make that decision. Again, like, I feel like we're in a society where we're just always critiquing each other, criticizing each other instead of working together. And so I don't know how we can have a united front, but I think I'm more for the local kind of control, and local, like, Texas says we're doing this, they're kind of doing this, because maybe if you're in Iowa, you're kind of already social distancing, right? You may not have the higher rates. So I don't know. I'm not saying I'm for the school opening. I just don't know, and I'm have the courage to say I don't know, because again, we have to be scared for the teachers too, because again, it's not just the kids. The kids are as far as children, it's not that significant of a disease. There are some some kids that die, and predisposed kids probably need to stay home. People with conditions need to stay home, but but as far as the teachers, that's where you're kind of concerned, because there are some 40, 50, 60-year-old teachers, and they're not in great shape. A lot
of teachers seem to be very concerned.
And these kids could be asymptomatic carriers, and so they can bring it to them too. So again, it's this weird balance. I don't know what the school districts are doing over the summer, but I was kind of hoping they did better curriculum for virtual learning. That would actually probably help. But I'm going to be honest with you, I'm blessed with a beautiful wife that's very intelligent, and that teaches our kids very well. So I have that, but I know there's a lot of kids out there that don't have that, and so they are not learning. Well, you remember when you were 16? You think you would have been studying right now? Like during, after spring break, they tell you you're not going back to school. I'm like, oh, sweet. I would have been on Nintendo for, for about, from like morning till noon, or morning till 3 a.m. So there's going to be a lot of kids that are not from, in underprivileged backgrounds, or, or God forbid, in abusive backgrounds. So it's such
and especially where, you have families that's where they get their 2 meals a day.
Yes.
It's school.
Yeah, there's so many factors here. It's like so weird. Like I hate having a political talk about this. I hate having a social media talk about this. There's like so many factors to consider, because
it's again, so complex and layered.
It's so complex. And again, virtual learning, if you don't have a good Wi-Fi connection at home, or
you don't have a computer,
or like, honestly, not everybody learns the same. And some people need a teacher.
Still in front of a computer. So I do 2 residencies a year for school, and we postponed it, and we're doing it next week. I normally go to Memphis for it.
Yeah.
And it's several weeks, all day for several weeks. But we're just doing 1 week through like Zoom or WebEx or something, and it starts tomorrow.
Yeah.
But the aspect that I'm going to be in front of a computer for 9 hours for a week, like, it's just like, that's not the same it's not the same kind of learning.
No, it's not. And we are, like, honestly, we're social creatures.
Well, you don't get the energy and the vibe.
No, like, I'd rather do this, like, when I was actually, what's funny is 2020, I was actually very optimistic for 2020, because I was going to, I told you I'd do videos. I was really, like, I was doing.
This wasn't on my vision board.
Yeah, this wasn't. So I was actually going to do a lot of, I was doing videos more for my Facebook and, YouTube and stuff. And I actually wanted to do more videos with people in here in my office together, because I think that interaction is so more engaging, right? So this interaction people are watching right now, but it's not as engaging because you and I are not physically there. Right?
The energy's not there.
Honestly, it would have been fun, like you and me hanging out, maybe getting coffee afterwards, something, like that social interaction is not there. So I think we're really missing out. You really wonder what the mental effects of this is going to be after a while too. Right. And so I'm actually kind of nervous for that, because I'm just like, even myself, and I consider myself blessed, like I feel a baseline depression. Like, I want to go out to eat. Like, I love going out to eat. I'm a foodie. I love, hanging out, going out different places, like we go bike riding with my kids, and we went to the neighborhood pool. But other than that, we're not getting out as much as we ordinarily would. So, yeah. And so it's crazy. I know people that, have 6 people in a 1,500 square foot house, like.
Well, it said, at that statistic that it said, where'd I put it? It was that in San Antonio, that 57% was close contact. That means within a household usually.
Yeah, and the CDC website actually says that as well too, that most transmission is through close contact. And it's typically that one person that does go out somewhere and gets it somehow. And
Right.
so and then you bring it back home, and so that can be it. The
Well,
other thing, go ahead.
go ahead.
No, the other thing I want that your listeners may be interested in is that there are some treatments that have been coming
Oh
out
yeah,
recently.
that was what I wanted to ask
Oh
you.
yeah, yeah. So when we're in the but they're typically in the hospital setting. Now in the outpatient setting, typically they're not they're just treating symptomatically, right? So they give you cough suppressants for cough, Tylenol for like fevers, things like that. So
Hmm.
symptomatically giving you medications, right, for whatever ailments you have. And just so you know, as far as symptoms, I've actually seen quite a few people not have the typical respiratory symptoms, the breathing issues, but coming in with nausea, vomiting, diarrhea.
I've
So
heard
more,
migraines. Is that?
that's a part of it too, like headaches, fatigue, all that stuff.
Mhm.
But what was surprising is some patients, I remember seeing a patient in the hospital, he literally just had abdominal pain for like a few days. And that was it, and he tested positive for COVID. And so, so the symptoms may not be there. So, but in the outpatient setting, you're typically, because if they're stable, you'll have a questionnaire or whatever, and they'll ask you how you're doing, you meet certain criteria as far as oxygenation, how well your blood is getting oxygenated. They'll
Mhm.
typically tell you stay home. So most people that get it, they're going to just be treated at home fine, symptomatically. Um, as far as in the hospital, though, if you make it to the hospital, they'll be treating you symptomatically as well too, seeing how you're doing and everything. But there are there's one medication in particular, two medications in particular that the FDA has rapidly or emergently approved for the use of COVID. One is remdesivir.
Mhm.
Remdesivir. So it's an antiviral medication, so it fights the virus. So but it's only being given to the most severe cases of people with COVID. So only the very severe. Also dexamethasone, which is a steroid. Steroids typically decrease inflammation in the body. And that's what
Mhm.
happens with COVID. You can have what they call a cytokine storm, where you have like all this inflammation built up. And that can actually have its own destructive effect on the body. So remdesivir and dexamethasone are the two treatments. Also, they're doing this thing where they're doing convalescent plasma. Have you heard about this, by the way?
No, I haven't.
So if you are out there, if anyone's out there that has had COVID-19, after about 2 weeks of you being asymptomatic, you can actually donate your blood to the Red Cross or whoever, and they can actually get your plasma out. And that plasma actually has those antibodies that we're talking about. And they're experimenting with that as far as on people that are, again, for the most severely sick. Not
Mhm.
not everybody in the hospital, but they're using that as well too. So convalescent plasma as well too. So those are the three things that they're actually using. Things they're actually
Um,
using in the hospital right now for the most severely symptomatic. The other thing I would bring up too, I'm a kidney doctor, so I'm going to give a shout out to the kidneys. So there is a pretty significant occurrence of kidney injury with COVID as well too. So with COVID, overall, I think there's a 5 to 10% injury, 5% rate of people getting kidney injury. Now, typically that's from dehydration. You're not eating right, drinking right, having diarrhea, nausea, whatever. So that's part of it. But so you're having that 5 or 10%. But people that are hospitalized, so 5 or 10% is people overall, that everybody
mhm.
that's got COVID. Now, the people that actually make it to the hospital, that actually make it into the building, there's like a 37% rate of acute kidney injury. So they're actually having kidney injury there too. So,
Wow.
there is a debate on whether COVID-19 actually directly affects the kidney, or does it just because it's having this inflammatory process in your body, lowering blood pressure, putting you into sepsis, putting you on the ventilator, all these other things, all these stressors on you, that it causes the kidney failure. So that debate is if the COVID-19 causes it directly, or if it's the other factors that go along with being so sick that causes the kidney failure. So
Well, have they seen? I mean, it may too early, but have you seen any data on cities that have a higher rate of kidney disease and as it relates to COVID?
you know
Like in
what?
the sense of cities that are more likely to be kind of what you would consider like unhealthy cities.
Yeah, well, Again, like the kidney disease. So just so you understand, with kidney disease in general, so people with kidney disease, we're not talking about with the acute kidney injury we're just talking about. We're talking about
Right.
people with kidney disease themselves that have, and typically comes from an injury over many, many years. So that injury is typically induced by either diabetes, high blood pressure, or vascular disease. Typically, that's about 65% of people with kidney disease in this country come from that. So preventable causes, or those causes themselves. So people, those cities that have high rates of kidney disease likely have high rates of diabetes, high blood pressure, and vascular disease as well too. So I haven't seen any studies afterwards, but I can imagine that's the case.
Just from people being,
Yeah,
or
but
immune system not being quite as strong as others.
yeah, that's what I'm. Yeah, so their overall health is compromised, and so again, like I don't think people. Again, this is a separate debate, but people don't take their health seriously, and there are consequences of not taking your health seriously. And COVID-19 is one of those consequences.
So is that 5 to 10% of injury to kidneys people that did not have kidney?
Yeah, that's what they're presuming. Yes, ma'am. So 5%, around 5 to 10%. So 5 to 10% of people
Well, that's
that
pretty
have.
high.
Yeah, that's high. But again, a lot of that can be from just dehydration, meaning you just got
Okay.
dehydrated because you're not eating right, drinking right, that kind of thing.
My,
So,
my dog has gotten a squeak toy.
oh, it's okay. Not a problem. Not a problem.
Hey, hold on. Come here. Sorry. Okay, sorry. I didn't mean to interrupt.
Yeah.
Okay, well, I have 2 more questions that I
Okay.
want to ask, and then we'll kind of wrap up. It's got to be aware of time.
Yeah.
And one is about back to mask, or the concept somebody told. I sent out like kind of an email or text blast last week and asked what people questions were. Pups. And one of the things that kept coming up over and over was people said that they didn't like to wear masks because they heard that you breathe in your own CO2, and that they said it could be damaging, which I didn't. It seemed a bit preposterous to me because I've worked in a hospital for a while, and so,
Yeah.
but I didn't know how to respond in a way a physician
So
would.
the likelihood of doing that, is very, very small. I mean, I can't imagine that maybe there is some component of that, but the CDC is recommending cloth masks. So cloth masks are pretty porous. So if you're breathing out CO2, that CO2 molecule is so small, it's getting out of the mask. Do you see what I'm saying? It's not going to be retained within that mask. So I wouldn't think it's possible, especially with cloth masks. Then you have surgical masks, which are like those rectangles that go around here, those surgical masks. Those, it's preventing CO2, it's preventing your mucus or whatever from getting out this way, but you're constant, the air is mostly getting out here and coming in here and here. So you should be okay. So I don't think that's a possibility. Then you go on to these other masks, like the N95 masks that typically have like they have one-way valves and stuff. So I doubt that's a high possibility. Again, I think right now you got to think about the more pressing issue. You're not going to get, the whole point is like you get too much CO2 in your system and you actually pass out because you have too much CO2, right? Or carbon dioxide. Right. That's not going to happen. That's not going to happen. And the more immediate problem is COVID. So I don't think that's going to be an issue.
Right.
So.
I've kind of heard that it was from a TikTok video of this physician that was like, if you think it's hard to breathe in a mask, just think how hard it is to breathe with COVID.
Yeah. No, it's true. It's like, it's so, again, like we can come up with excuses for it. It's a pain. Don't get me wrong. It is a pain.
No, I mean, nobody enjoys wearing a mask, but
no one enjoys it. I mean, there are some cool masks now. So if that makes you feel better, get a cool looking mask with those little fake filters on them. That I love those. These are nice little toys you got on them. But if it makes you feel cool, please do it. Please do it.
So one last question, or 2 really. What about, have you heard anything about blood types? People that have certain blood types that.
Oh, yes. So I looked this up. So so as far as blood type, so initially I think out of Wuhan, and then some early studies out of New York said that people with type A blood type are more likely to get have a positive test for COVID and have worse outcomes. And somehow blood type type O people are less likely to have those things happen, right? So they're more protected. Now, I've heard that recently more studies are coming out disproving that. Again, this is a fluid moment. So just because you have type O blood type, whatever, don't think you're protected. And if you're type A, don't be like anxious and worried. You know what I'm saying? So because to me, like a lot of this, you got to remember when you go to the hospital, or even when you go to your PCP, we're not checking your blood type. The only time
Well,
we
that's what
check,
I'm saying. All these tests that people have, unless
yeah,
you have blood drawn, or just
yeah,
they don't ask you that. So how are
no,
these
even
people even gonna?
when we draw blood from you, we're never checking your blood type. The only time you're checking your blood type is if they're going to get a blood transfusion or that you're going to make a blood donation.
So
That's
how
the
would the
only.
data even represent that?
So
It's
I would wonder, like maybe some certain people, that like were in Wuhan, China, or even New York when this all started, that were really bad,
mhm,
really,
like a
really
specific
ill.
study or something.
Yeah, no, well, not even say. I think maybe they were the worst ones, and they required blood transfusions.
Okay.
Perhaps there was more need for A versus O. I don't know. So I don't know how they came to it. But what I've read is it does not. This is not something that you consciously, as a patient or person, should be worried about or even think about, because again, maybe in the future. This is something we need to look back retrospectively. This is not
Right.
something we need to be like right now. If you're type A, stay at home, don't come out, and type O, go to Padre Island. Like it's not that. So I think again, in the fluidity of the moment, please do not think that that's a big deal. This is something retrospectively. Perhaps there is data there. Perhaps it is important, but I would not worry about it too much at this point.
Okay. And to kind of leave on a more positive note, in your opinion, what are some positive developments that have come out of all this pandemic? I mean,
Yeah, it's hard to see positivity in any of this, right? Because I'm actually like, this is the worst year ever. Like, you just want to take a mulligan on it, right? You just want to take a mulligan on it and be like, hey, can we just go from
the red
2019 to
dust and the
2021?
murder hornets and the
Yeah,
like,
yeah. This is just the most worst year like I can imagine we ever had.
rebellions. Yeah.
Yeah, rebellions. Shoot, Federal Reserve making up money, like 3 trillion, more money. I mean, but
The
anyway,
aliens, there was another one that there was like this comment and like was like, okay, wait a
maybe they
second.
would save us. Maybe they would actually come and save us.
Or they'd be like, we're not going there quite yet.
Yeah, it depends on depends on the alien. Is it Independence Day alien or is it, like it depends on the alien, I guess, the species. But actually, if an alien did come down, it may actually make us come together cohesively as humanity to fight it. So that may be a benefit, right? So, but anyway, I would say one of the biggest things that come out that's really positive is telehealth by far.
Yeah.
Telehealth is amazing because especially this experience for a patient. And so what was amazing was, and this goes to another aspect of it, but what was amazing, especially with telehealth, was the ability of Medicare and a lot of these commercial insurance payers to reimburse for this new visit, right?
Mm-hmm.
So they switched over and gave us or let us pay, covered us for this. Now it's a lot of practices took some time to develop this because again, there's a whole series of qualifications or metrics you have to have in your note to justify a telehealth visit. But once you switched over, it's actually a great experience. I think it really helps those in underprivileged areas or underserved areas, like the rural areas that can, don't have to drive 50 miles, 100 miles to their doctor because they don't live in San Antonio. So it's a great experience there. Now, I don't think it's going to completely substitute for a physical visit because some patients, honestly, I need to see them physically just to assess them properly, make sure they don't have swelling in their legs. Because it's, it's hard to get a patient to angle the camera down properly. And even then looking at them or listening to their lungs, like actually physically listening to their lungs, I'm kind of, missing. But in general, it's been extremely positive development. I'm hopeful that they'll incorporate this into medicine as a whole. And this will be a part of our practice and kind of innovate medicine as a whole. And maybe even come up with, who knows, like, equipment like I know that they have this equipment, but like maybe you have a stethoscope at home, a machine that measures your vitals for you, I don't know, and it measures your blood pressure, your blood sugar, blah blah blah, and you put it onto your heart, and I listen to your lungs, I listen to your whatchamacallit there. Now, one of the problems with the telehealth though is older populations are very difficult to transition to it.
Mhm.
You know, I have this thing where I've seen a lot of 60-year-olds do not know how to use you know, their cell phone. I would say most 60 people or 60 years or older, they automatically think if they have a smartphone, they have an iPhone, right? It's actually pretty funny. It's just like, it's an iPhone. And it's like, no, it matters. The matters because I have to decide to message you on either telehealth, visit you on Google Duo or FaceTime or a different platform, right?
Right.
So my MAs actually, when they call these people, they go ask them, what kind of phone do you have? It's an iPhone. They'll actually ask them to turn the phone to the back. Is there an Apple back there, to verify that they have an iPhone? Because otherwise,
Really?
yeah, yeah. And so, and then a lot of times you'll be on the phone and all you'll see is their forehead. I'm like, no, please circle it down. Or you're listening, you're seeing a picture of their ear for about 10 seconds before they realize it's a phone call. So there's a lot of little hiccups there. But overall, that's by far the most positive development I've seen. Also, I mean, I think this, the rapidness of the response, how fast like Medicare and stuff has been able to reimburse this new televisit.
Right.
I'm hoping it's here to stay, and then the commercial payers stay with that. Commercial insurance companies, they do too. But you know, even like the drug approval and you know for vaccines,
Mhm.
why, you know, how are they doing this in 3 months when it took them 3 years before? You know, like, and again,
Right.
I'm not saying it's the half-ass they're going is right, but you know, a lot of this stuff, like how are they doing this? So it's a there's crises represent opportunity a lot of times too, right?
Mhm.
So I think America, as America, we should be proud that we always evolve, right? We always kind of change, we always kind of adjust and adapt. You know, and I'm hopeful that after this we can continue to adapt and evolve different technologies and stuff like that as well too. Even disinfecting, you know, like maybe we'll take disinfecting a little bit more seriously, or in hospitals at least, excuse me, not necessarily over there, but hygiene. Like I've learned how to wash my hands properly for the first time. Right? I didn't know I was supposed to do it for 20 seconds. Okay, don't. That's between me and you. Okay, that's between me. All right. No, so, but what's fascinating too, Colette, I know you just started doing these videos and stuff, but what's interesting is when
Mhm.
you actually start doing these videos and you start researching, you actually learn a lot. And so that's what
Yeah.
I've actually found, that it's so cool. Even from my own medical perspective, like when I did my video on COVID-19, like I learned a lot. And so, you know, and so I feel like, and learning the washing the proper hands, I mean, I knew generally how to do it, but things like that, like you learn a lot. So that's what's cool. And that's what's cool about your experience doing this, I think.
Yeah. Well, I mean, I have a friend of mine that I interviewed, Dr. Whitney Mitchell, and she's a psychiatrist, and we talked a little bit about telehealth, and she was like, you know, it's modern. This has kind of modernizing because
Oh,
she
absolutely.
said, you know, it for so long, you know, not doing telehealth that with the HIPAA has like what has kept fax machines in order for so
Yeah, look,
long.
it's literally
Said, you know, it's
stupid.
ridiculous. And now
Oh
we're
my.
shifting toward the modernization of what medicine
Yeah,
is.
it's so weird. Like in medicine, fax machines were HIPAA compliant, and I'm like, what is this? Like seriously? Like this is not 1996. Like what are
With
you
your
talking?
pagers and your fax
Yeah,
machines and
yeah.
your
And this is the weird thing.
laser
So
discs.
a text is not, a text from on my iPhone is not HIPAA compliant, but a page on this antiquated analog machine on my belt clip
Right.
was, you know, like I didn't understand the logic here. So maybe
Mhm.
it helps people in the regulatory space, but also technology space make things come about quicker,
Right.
and you know, evolve quicker. And who knows? I think there's going to be a lot of possibility. Even, you know, what's fascinating too, you know, like you wonder, like even when we were doing the whole shelter in place thing, you
Mhm.
know, there were so many people not coming to the hospital. Now I wonder if that was from just fear, you know, of
Mhm.
not coming there, but the hospitals were empty, like they were empty. And I still wonder what that reason was. And you wonder, maybe people were overutilizing the healthcare system, you know, like the ER, like they once were. You know what I'm saying? Like
Right.
taking that boo-boo or that little thing. And we learned actually in that scenario to actually manage people as an outpatient better too, and say, hey, I'm not sending that patient to the hospital. And so I'm going to manage this as an outpatient, get them the antibiotics as an outpatient, get them the treatment as an outpatient, do everything as an outpatient. And so what you do, and this is another talk, but when we're doing that, by keeping them outpatient, meaning out of the hospital, you're actually saving healthcare dollars, because the biggest cost in
Well,
American
yeah.
healthcare is the
Well, I mean,
hospital.
Texas is such a high rate of uninsured people. And so I
Yeah.
remember when I was at University Health, I mean, because it served like, was it 31 counties?
Yeah.
And most of the people that were uninsured went to that hospital. And so
Yeah.
it was because they didn't have a primary care physician that they go
Yeah.
in. So they
Yeah.
went into the ER, and it just sucks up money and time.
But not just the ER, but with the hospitalization itself. Like, you stay in the hospital, you're costing insurance, $1,000, $2,000 a day, or for
Right.
$3,000 a day, depending on what you're doing. So it's really expensive. So if in this scenario we learn, hey, how do we better manage outpatient people and keep them out of the hospital, and say, hey, don't go there. And that's what we're doing a lot of times, because I'm like, I don't want to send that patient to the hospital. Like, I'm actually thinking this, like, oh, this patient's got these symptoms. All right, I'll bring them to my office real quick. Or maybe I'll just telehealth visit them real quick and see. So I'm actually saving healthcare dollars by not sending them to the hospital.
Right.
Maybe that's something we'll actually learn and say, hey, you know what? We have strong criteria for admission to hospitals now. We need to send these people. And even what's funny is the ERs would call me and say, hey, man, I want to send this guy home. I don't want to really keep him in the hospital. Awesome. Let's go. So maybe we'll change that criteria, and that'll be good.
Yeah, and people having to take off work, and people having to get their kids, and I mean, the whole domino effect of people having to actually physically go into a hospital.
Oh yeah.
Yeah.
No, the hospital it's so that's where we can save healthcare dollars as well too. So that'd be awesome. So cool.
Well, I just want to say thank you, Dr. Butt, for being on. I really enjoyed it. And
No, it was fun.
I
It
will
was
leave a
fun.
link. Can you tell people the name of your YouTube channel and how to get a hold of you on Facebook?
Yeah, so I'm actively on social media. The main platforms I'm on are Facebook, LinkedIn, Instagram, and YouTube. So you can reach me. My YouTube channel is called Your Kidneys, Your Health. That's kind of my tagline or whatever. But if you want to reach me, it's at Qasim Butt MD, at QASIM Butt BUTT MD, and you put that in any platform, anywhere, Twitter, even Twitter, whatever. You can catch me there. So
And his videos are very entertaining and very they're fun to watch, and
I
they're not
appreciate
like
that.
super. Yeah, they are. I've watched some before, like when you were recommended
Awesome.
by Dr. Anil and Colette. So
Yeah.
thank you so much for coming. I look forward to maybe exploring videos with you on that where we can dive into other avenues of
Absolutely.
health
Maybe we can have coffee after the zombie apocalypse sometime, right? At some
after
point.
the hornets and the bees.
Yeah, so after the Walking Dead scenario plays out.
Right.
So.
All right.
Awesome.
Well, thank you. And I'll leave a link below when I upload a video to how people can get a hold of you and follow your platform as well. And just want to thank you and really appreciate it.
No problem. Take care, okay?
All right. Bye-bye.
Bye. All right. You got it?
Yeah. Hold on. Let me